second session, and it gives me great pleasure and honor to present our first speaker, Professor Yaqub Khalaf. Professor Khalaf is the Professor of Reproductive Medicine and Surgery at Guy's and St. Thomas's and at King's College in London. Yaqub is a member of so many advisory boards all over the world, which reflects the high esteem everyone thinks of him. And it's our pleasure to hear from him about, let's talk about misconception and assisted conception. Welcome to Amman, Yaqub.
Here we get my slides. Thank you very much, Khaldoon. It's always a pleasure to be in Amman and see a lot of friends. Now, the title, as you can see, talking about some misconception that influence our practice of assisted conception and sometimes go unnoticed. It is something that I feel so strongly about because patients entrust us with something very important in their life to help them have a baby, and they don't need to spend every single pound they have in their pocket to reach that game, because the process in itself is demanding financially. I think you gave me the wrong presentation. This is my presentation number 2. If you are happy to hear it, I'm happy to give it. Okay? This is the second presentation. Yes, you have. No, أبعت الاثنين. Number 1 first, number 2 second. But I'm happy to launch into this to not to waste anyone's time. Yeah, exactly. It doesn't matter. We can talk about this and that. Okay? Okay, so let's talk about misconception. Because what we do is not very profitable. The outside world will think that just because the patient came to have IVF and it is the ultimate technology, she's guaranteed to leave the clinic with a baby. The truth is not like this. And because the truth is not like this, we fail patient expectations, so we start improvising and give them the good and the bad and the ugly. And that is the day-to-day practice that we see in. And one of the issues that we completely don't pay attention to, the mismatch between patient expectation and what we are able to offer them. And sometimes to try to cover this gap by giving them, as I said, everything in the book or even outside the book. And one of the biggest misconception in assisted conception, particularly now, I'm not taking them in order, that those who have difficulty producing good number of eggs, or they have low ovarian reserve, there is an industry nowadays called ovarian rejuvenation, which effectively, you don't need to hear me about how difficult it is to turn the clock back. It is only enough for you to hear Kulthum saying, وعايزنا نرجع زي زمان, قول لزمان نرجع يا زمان. It's no different with ovaries. The patients are born with a finite number of eggs. Once they get reduced in number and reduced in quantity, there is no power on earth that can turn the clock back. But we're still seeing people spending huge amount of money for something that is nothing but snake oil. I'll come back to snake oil later. And I hope if there is anything to be taken from this message, when you hear about someone using PRP for ovarian rejuvenation, you should stop seeing that person in the same way ever again. Because this person is either ignorant or greedy or both. And this is a deadly combination when ignorance and greed will combine together. Why? Because you think about it, it's like hourglass. The hourglass, all what is above has come down. What you are trying to convince your patient with ovarian rejuvenation, that you can turn the hourglass and what came down can go up, which is physically impossible. Anyone has any issue that ovarian rejuvenation in their hand works? Of course, I look frightening, nobody will dare. Anyone believe in ovarian rejuvenation using PRP? Then my mission is accomplished from this aspect and I don't need to speak about it any further. And because I don't have slides, let's talk about immune suppression. People use immune suppression, whether it is steroid, whether it is intralipid, whether it's intravenous immunoglobulin, because they live with that misconception that the body rejects the embryo. And that assumes that the embryo is allergic or immunogenic. And both assumptions are wrong. That the tests that we use have been validated and have specificity and sensitivity and predictive value and all of that, and none of that exists. Anyone in a man measures natural killer cells? Anyone? Anyone use immune suppression like intralipid or intravenous immunoglobulin or steroids? I am in the wrong place, obviously. They don't have anything to change. So in the place where I practice in London, in the center of London, there are people who will cause the patient the airs in testing natural killer cells, in testing Th1 and Th2 cytokines, in giving them intralipid, intravenous immunoglobulins, and these are agents that can be not just draining financially, but they can be harmful. And anyone who tells you, my body is rejecting the embryo, you need to be empowered to say that this is a fanciful idea, has no basis biologically. I think I finished my talk, but we can carry on. So that is one of the biggest misconceptions too. The other misconception is when people have a patient who did not have success, shall we? Okay? Yeah. That's okay. We'll go through the bits that I said quickly. So here is the misconception in IVF more than the truth, actually. And it is a very heavy burden for us because you can't fit all the add-ons that are used in assisted conception quite wrongly in one slide, as you can see. And those misconceptions, I can't cover all of them. I already delved into ovarian rejuvenation. And we talked about how it is much of a misconception because to rejuvenate, to turn the clock back, to make someone young, to restore the original or the new status. And people don't appreciate that the ovarian depletion is starting from early on. You can see in a 10-year-old girl, the ovary is packed with follicles. At 20, it is much less. At 30, is much, much less. So the process is physiologically and biologically part of reproduction. And the hourglass stories that I told you about, once the patient is born with all that she has, and then there will be gradually reduction in the number until the patient does not have any and there is no power on earth can rejuvenate. The mechanism for ovarian reduction in size and function of the eggs is so complex and it is multifactorial. And you can go to Journal Reproduction, which has a review about the mechanism of ovarian aging, and enlist ovarian fibrosis, genetic mutation, mitochondrial dysfunction. It's not expected that injecting platelets will deal with all of that because it has to be a panacea, the answer to all diseases to do that, and that is impossible. And we see this in IVF, whether it is in Amman, whether it's in the United States, always will be influenced by age, no matter what. Wherever you do it, Cairo, London, Mozambique, the same. So no, but when people market PRP, they will say, this is a stem cell. And when we hear stem cell, we get excited. That will cure everything. And that is what I mentioned by saying snake oil, which means really when people try to sell fake or ineffective product, what is their tool of doing that? They will quote papers from other disciplines, and they will say platelets carry more than 800 types of protein, cytokines, etc. You look down, that is in the Journal of Aesthetic Surgery. It can be used for cartilage, it can be used for skin, but the ovary have finite eggs. The same, they will use the activation of platelet-induced release of variety of biologically active protein. Will it reverse the depletion? Will it reverse aneuploidy? it doesn't. The painful reality, when people studied this objectively, they could not demonstrate any benefit. No clinically significant effect of PRP treatment on ovarian function were observed after 1 year of follow-up. The same in another credible study in human reproduction. The same in a Cochrane review. The Cochrane review exposed all the ills in those studies. They are really very poor studies. There is no report of live births. There is poor reporting methods, lack of prospective control registration. So you can see it is a short circuit. The misconception of improving outcome of poor responders follows the same. Here is in the center of London. A doctor saw a patient whose ovarian reserve was a little bit less than it should be. See how she was stimulated. It makes you cry. And by the way, he's a very famous doctor. The patient was started with 600 units of gonadotrophins. And after 5 days, changed from one thing to another, with 600 reduced to 450, and the improvisation continued every day, and every day she's going for a blood test twice. I can submit to you that Leon Spirov will not be able to interpret 2 blood tests in 1 day. But money talks. And then, as if this is not enough, this patient was having citrotide, that is fine, was having Clomid 100 milligram, was having Viagra, not sure for her or for her husband, she was having Clexane, she was having aspirin. And this patient really got nowhere. She only got bankrupt nearly. Needless to say, I wouldn't have had her chart if she didn't come for treatment. And believe you me, we gave her nothing other than standard dose of gonadotrophin, combination of HMG and FSH to the total daily dose of 375. Was seen after 9 days, no blood test. Just seeing the follicle and size, and had egg collection on day 11, and she produced 4 or 5 eggs, I can't remember. The main issue, without all of this Mickey Mouse stuff, she had a baby from the first attempt. So you don't need really to be so, I don't know how to describe it. It is more than misconception. Here is one of my patients. Her AMH was 0.8 nanogram, which is 5.6 picomole. This patient had, I think, 7 cycles, because she was banking embryo. She has a very nasty genetic condition. She needed a lot of blastocysts in order to get a healthy one. This patient had exactly the same medication, cycle after cycle after cycle. It is combination 225 recombinant FSH and 150 HMG. Short protocol. It has not changed in all of these 7 cycles. And look what happened. In one cycle, she got 4 eggs. In the other, she got 2. In the next, she got 1. In one of the cycle, got 10. If you assume that you have used any intervention between the cycle that she had 1 and the cycle that she had 6, you will always attribute it to what you've given, and not paying any attention to biological variation that does happen regardless of what we do, if you stick to the basic principle. And you can see the number of blastocysts that the patient had despite having modest number of embryos. So the misconception of considering recurrent implantation failure as a disease. The patient has an IVF cycle. Some people will call it recurrent implantation failure. 2 or 3 recurrent implantation failure. Are we really accurate in giving patient labels? Because recurrent implantation failure is not a disease. It's only a description that the patient had embryo transfer and she did not have success. Were we expecting every patient to succeed? If you expect you have a patient who's 39 or 40 coming for IVF and you expect her to succeed from the first cycle, you are in the wrong business. In actual fact, at any age, the chances of failure are more than the chances of success. And this hopefully will come in the next lecture. And failure or recurrent, what we like to call recurrent implantation failure, it happens in natural conception. How many patients will have a baby from the first intercourse or the first months or the first 3 months. Only after 12 months, 85% of those patients will achieve their outcome. So it happens in assisted conception. Not every embryo will implant. So simply because not every embryo is destined to make a baby. If you don't believe me, here is the natural conception. The patient does not have any infertility. This is a cohort depending on their age. They will carry on, some of them getting it first month, second month, third month, on 12 months. It's no different from assisted conception, where you see patient at any age, after 3 attempts of IVF in patients under 35, only 2/3 of them will leave the clinic with a baby. The remaining cohort will have to continue trying. It's never flat line, because the more attempts they try, the higher the curve becomes. So, and most of this because of aneuploidy. We know that aneuploidy is age-related, but when it comes to recurrent implantation failure, people did a study where they looked at 3 subsequent embryo transfer of euploid embryos and find after those 3 cycles, only 4% failed to achieve a pregnancy. If you increase the observation to 5 euploid blastocysts, you will end up with 2%. So it is something that we take as a disease. And when you look at the age, different age group, this is a younger, this is the older. The more attempts they have, the curve is always in the ascendancy. The moral of this, if you are to make any investment, make it in a new cycle, not in giving patient snake oil. Recurrent implantation failure is a description, not a disease. And the answer is to really keep trying rather than wasting the money on something that doesn't work. How about the misconception of relying on biological plausibility? And I'll give you an example. People believe that if it talks like a duck and it walks like a duck, it must be a duck. That's not true. It could be a dragon impersonating a duck, and that is totally different story. What do I mean by biological plausibility? People talk about, say, let me give you an example. DNA fragmentation happens because there is excess oxidative stress, and as such, it affects the outcome of fertility treatment. If we reduce the oxidative stress, then fragmentation will be reduced and outcome will improve. It follows that we test DNA fragmentation and we prescribe antioxidant and we seek other sources of sperm, sometimes from the testes rather than from the ejaculate. And then because of our belief in the biological plausibility, we ignore the important part of the story. Have we demonstrated this in a randomized control trial? There is none of that. So what is the impact of DNA fragmentation? Does DNA fragmentation or DNA integrity test predict male fertility with natural conception? Does it predict pregnancy with IUI? Does it predict pregnancy with IVF? The answer to this is no, it doesn't. Is DNA fragmentation predictive of pregnancy loss? The answer is no. You don't have to believe me, but look at the literature. Current methods of assessing sperm DNA integrity do not reliably predict treatment outcome. Why are we testing? And that is not yesterday, that is 12 years ago. Cochrane Review, 2017. Antioxidant for female infertility doesn't work. For male infertility does not work. 2017, 2019. Antioxidant for male subfertility. Subfertile couples should be advised that overall current evidence is inconclusive. Ineffective intervention. The randomized control trial, when it was tried on antioxidant that everyone is prescribing like Smarties, it doesn't work because the result of this important randomized control trial had a conclusion that antioxidant treatment for male partner does not improve semen parameter, DNA integrity, in vivo pregnancy in couples with male factor infertility. Does it have any relationship with miscarriage? Absolutely not. If any relation, it is association, and association does not mean causation. Why are we wasting our time and our effort and our patients' money? Only yesterday, or the day before, this paper was published. In huge number of patients, DNA fragmentation index did not associate with assisted reproduction outcome. So how much more evidence for us to move on from spending the money on a test that does not add value? When I have a couple asking for DNA fragmentation test, I say, go and book a table for 2 it's much better use of your money to have dinner together than to spend it on a test that is useless. And I spoke to you about the شماعة الimmunology, where people talk about the embryo as if it was a grafted organ. Does the embryo or does the body respond to the transferred embryo as a transplanted organ? The answer is no. Why? Because the embryo is expected. The body is waiting for it. It has the progesterone, it has the decidua, it has everything. But the implanted kidney or transplanted kidney is a foreign body. So the immune system quite rightly will have that. And the reason for the difference is tolerance. And people have shown that with pregnancy, as soon as ovulation sets in, the system is anti-inflammatory. Before this, the system is pro-inflammatory. So whether you believe or not, it is an intelligent design that prepare pregnancy to happen. Otherwise, we wouldn't have 8 billion people in the face of the earth. And if you wanted to read more about this, you can go and find an article available free about contribution of immunology to implantation failure of euploid embryo, almost none. So among the potential immune causes of reproductive failure is measuring Th1 and Th2. Th1 indicate pro-inflammatory status, Th2 increase anti-inflammatory. The bottom line, because I use the time twice now, is there is variation of that Th1, Th2 depending on the state of the patient. And as I mentioned, the Th dominance occurs around ovulation, and the inconvenient truth, effort to improve outcome by favorably altering Th1, Th2 ratio to become more in favor of Th2 have been complicated, and they are not reliably used for testing. Before conception, no difference in the immune system. In fact, it is normal for Th1 to dominate before ovulation, and no screening test is available. Natural killer cell, they never killed anyone as far as I'm concerned. And Ashley Moffat, who gave them this name, never regretted anything in her life than giving them this name, because they only kill virus-infected cell and cancer cell in vitro. But we still measure them in blood, paying little attention that they are different from the one inside the uterus. So measuring natural killer cell is not clinically relevant. So we can't do Th1, Th2. We can't rely on natural killer cell. What should we do? We go back to the basic principle. When you do a test, you ask yourself, what is the prevalence, sensitivity, specificity? And for this, it is non-existent. And you can challenge me and go and look for the prevalence and sensitivity and specificity of natural killer cell, none. And you look at the other, non-existent. So if we can't have the proper testing, what do? We ignore the evidence. Because the evidence is clear. There is a paper published in JAMA, big randomized trial, gave steroid in one arm, didn't give steroid in the other, or gave placebo. The outcome was 38% with prednisone and 39% without it. So the guidelines, quickly, we have the ISHRA guidelines talking about immunology testing and treatment that they are not recommended. The traffic light of the HFA, talking about immunological test and treatment, they are scoring red, which means they are useless and they can be harmful. Immunological test and treatment of using glucocorticoid, red, it is useless and it can be harmful, etc., etc. Steroid, the same, can be harmful. Intralipid, there is no studies even to show whether they work or not. Intravenous immunoglobulin, it can be harmful. And the Canadian Society for Reproductive Medicine sharing the same observation. But for those who are intent on getting money out of this, no matter what, they will say, so what? Who cares? And they have every reason to do that. Why? Because to test natural killer cell, you have to pay £610. Good money. You pay it for Th1 to H2, you will pay 460. And if you wanted them combo, you can make saving for 940. So you can see why people are driven to do that and sell snake oil. This is one of the most accomplished immunologists in the whole world, Sarah Robertson in State. This is her book, and she said suppressing the immune system will not improve the chances of conceiving IVF, but still, people who are intent on selling something, so what? Who cares? Because it's all for sale. Here is what it costs to use IVIG. If you use IVIG, you pay £3,500 per shot. One of the patients who came after having this treatment, she told me, she was a doctor actually, I wasn't counting the number of drips. I was counting 50 pounds, 100 pounds, 150 pounds. So you see how sad it is. So you ask yourself that important question, why people do what they do? If we don't have validated tests or proven treatment, why are we exploiting patients? And there are people who are in position of power. They are meant to set the standard for health care. They are up to their eyeballs with this cookery. And here it is, the answer. It is either bad intention because money is what counts, or it could be good intention but poor understanding. And you ask your question, how much money is enough? So that is the dilemma that, and if you talk about immunology, and you look at as I quoted you earlier, after 5 cycles, the rate of success, if you are putting eubloid embryo, is only 2%, the rate of failure. What is left for immunology? But people who are intent to making a killing will make a killing. So here is my take-home message. The best financial strategy is not to waste resources on unproven, unhelpful, and potentially harmful add-ons and save it for another treatment attempt. That is the best use of the money. Thank you very much.
Thank you very much, Yaqub, for this wake-up call, I should call it, for many people. We have time for a couple of questions. Please state your name, where you are working, and make it a short, direct question, please.
Yes.
Dr. Gamal, can you have the mic there? Tfadal.
Thank you very much. Thank you very much, Professor Yaqub, for this excellent presentation. I just want to have a comment, actually. In one of the meetings, scientific meetings, somebody was talking about PRP, and then he raised his hand and said, I do it. I said, why? Because there is no evidence. He said, Dr. Surur, it is sabooba.
بالضبط. We have to make a choice between doing medicine or doing business. We can't do business, but honorable business with medicine too, but not in that dishonorable way. Yeah.
Another question, please.
Yes, hello, good morning. Thank you very much for the nice lecture. I'm Dr. Rima Farah. Yeah, the golden question, or I'm expecting from you the golden answer. How do you convince a patient with recurrent IVF failures that you have to repeat and repeat and repeat without all these medications that you
I think that
mentioned?
that question will hopefully be answered comprehensively in the next talk about counseling patient after failure, but the story is simple. If you explain to her that the stakes are with the embryo and with the lining of the uterus. If the embryo is being produced and the lining of the embryo does not have any pathology, not every embryo is destined to make a baby. And if that is the case and they accept it, they have to try, because then the embryo that is destined to make a baby will come in the process. Yeah?
Thank you very much.
Pleasure.
Thank you.
Right, the second speaker is Professor Jamal Abu Surur. He's a professor of obstetrics and gynecology, director of the International Islamic Center for Population Studies and Research at Al-Azhar University and former dean of Faculty of Medicine, Al-Azhar University. He is the past president of the International Federation in Gynecology and Obstetrics, FIGO. Professor Surur established with 2 of his colleagues the first IVF center in Egypt in March 1986 and delivered the first Egyptian IVF baby in July 1987. Currently, he is also the president of the board directors of IVF Center at Al Maadi, Cairo, and president of the Egyptian Fertility and Sterility Society, which is EFSS, and the president of the African Federation of Fertility Society, AFFS. His presentation today will be about myomectomy for infertility, when and how. Professor Surur, please.
Thank you very much, Mr. Chairman, for this very kind introduction. I just would like to sincerely thank my colleagues and friends, Dr. Mazen, Dr. Abir, and Dr. Maher, for inviting me to this very important meeting and to come to this beautiful country. Well, it's very difficult to talk after 4 distinguished speakers coming from UK, and I think I'm the first person to talk to you from our region. I come from Cairo, and of course we have the same situations, we have the same financial situation, we have the same medical practice. So I think probably my talk will, I hope it will be relevant, particularly for our young colleagues. My talk is about myomectomy, because these are the questions which are frequently asked, doctor, do I have a myoma? I do have a myoma. Does it affect my fertility? Should I remove this myoma? If removal of the myoma is going to help me to get pregnant, or does it have a negative impact on my ability to conceive? And in this presentation, I'm going to try to answer this question because we do get these questions frequently asked in our practice. Well, first of all, we have to know that myoma is one of the most common tumor in female. It exists in about 60% of women below the age of 50. However, as the only cause of infertility, this exists only in 2 to 3% of the cases. It does exist with other causes of infertility, but as the only cause of infertility, it is only in 2 to 3%. So having a myoma is not something very abnormal. It may affect fertility, it may not affect fertility. And then we come to the question, when do I have to remove the myoma? We have to remove the myoma if it has a deleterious effect on the outcome of fertility and on the outcome of IVF. So what are the myomas which have a deleterious effect on the outcome of fertility or IVF? Well, certainly the submucous myoma. It had been shown that the removal of a submucous myoma, it does improve fertility by about 50%. Studies had shown this very clearly. And also studies had shown that subserous myomas, they have no impact on fertility whatsoever. Now, when we come to the intramural myoma, we have a problem. The problem is that some of the intramural myoma are distorting the uterine cavity, and some of them are not distorting the uterine cavity. And certainly, those intramural myoma, which are distorting the uterine cavity, they do have a deleterious effect. All of us have seen many myomas, which is compressing the uterine cavity, and you cannot introduce even the catheter to pass the embryos inside the uterus. And so there is no problem about intramural myoma distorting the uterine cavity, particularly if they are multiple or if they are large size. Now, these slides are being fixed, so I shall go quickly. I shall not repeat what I mentioned. I just go. Yeah, this is, of course, the FIGO classification, which clearly shows that there are different types of myoma. And you would not expect the myoma 0 type or 0-1 will have the same effect as the myoma of degree 7 or 8. And as I mentioned, that the intramural myoma not distorting the uterine cavity is the real problem. And the problem is because all the studies which had been published, they did not correct for the number of myoma, the age of the size of the myoma, the proximity of the myoma to the endometrium. And for the intramural myoma, which does not distort the uterine cavity, it does have some deleterious effect because of the pseudocapsule, which produces oxytocin and neurotoxin, which result in peristalsis, which might impair implantation of embryos, and also because of the change in the implantation factor, like HOXA10 and HOXA11, and glycodyline, there is a decrease in the implantation factor, and also because of the change in the immunological and endocrine factors, because of the pseudocapsule, because of the junction zone, because of the decrease in the natural killer cells and increase in the macrophage cell. As Professor Yaqub was mentioning about immune effect, we have not to forget that during the luteal phase and the production of the corpus luteum, there is production of progesterone. And the progesterone itself is immunomodulator. And women have been getting pregnant all the time since the time of Eve and Adam. And there was no rejection. There was no immunological suppression of the embryo. So this means that intramural myoma not disturbing the uterine cavity might have a deleterious effect. As I mentioned, because the study did not correlate and did not look into the number of fibroid and the size of fibroid, and one of the studies which really looked into this and the size of the fibroid and the number of fibroid, this was a study coming from one center. It was a retrospective, matched, single-center cohort study, was performed analyzing women with non-cavitary disturbing myoma on the effect of IVF. And the study included 163 patients and compared it with 326 control. And 40% of the patients had single fibroid, 58% of patients have multiple fibroid, and the median size of the fibroid was 25 millimeter, and the range of the size of fibroid varied between 1 and 10 centimeter. And when you look at the outcome of this concerning the live birth rate, all in all, yes, there was a deleterious effect on the outcome of IVF in this patient. However, when they looked into the live birth rate in patients who have one fibroid, then there was no deleterious effect on that. But when they looked into the live birth rate in patients who have had more than one fibroid, 2 fibroids and more, then there was a significant reduction of the live birth rate. So if you have a single fibroid, there was no deleterious effect. If you have 2 or more fibroids, you have a deleterious effect. And when you put them together, then you say all of them have a deleterious effect, which is not true, because single fibroids, they do not have a deleterious effect. And when they looked into the size of the myoma, whether the myoma was 3 centimeter or more than 3 centimeter or less than 3 centimeter, they found again that for fibroid with a size of more than 3 centimeter, there was a deleterious effect. When the size of fibroid was less than 3 centimeter, there was no deleterious effect. And I think this is one of the good studies which can help us to differentiate and choose the patient-specific management in this patient. And the conclusion of this study was that the presence of intramural fibroid not distorting the uterine cavity appears, it didn't say it does, appears to negatively affect the clinical pregnancy and live birth rate in patients undergoing their first IVF and ICSI cycles. And the deleterious effect of fibroid was significant in women with 2 or more fibroid and in women with fibroid more than 3 centimeter. Conversely, in patients with single fibroid, less than 3 centimeter in diameter, no significant difference in pregnancy outcome was identified. Now, also 3 meta-analyses appeared, one by Sunkara, and the other by Wang, and the other by Rickhan, and again, the same conclusion that non-cavitary disturbing intramural fibroids are likely to have a negative impact on clinical pregnancy and live birth rate following IVF. However, as I mentioned earlier on, the heterogeneity of the study and the methodology and the proximity of the fibroid to the endometrial cavity or others, these are factors which has to be considered. Now, so the other question we are asked by the patient, when to remove the fibroid. Is it necessary to remove the fibroid? As I mentioned earlier on, certainly it is not necessary. It depends on the location of the fibroid and the size of the fibroid. The problem is we do not have prospective randomized control study except one, which compared between the outcome of removal of the fibroid on fertility. And that study actually did not show significant difference in the pregnancy rate following removal of fibroid. It was slightly higher, but it was not significantly different from those patients who did not have the removal of the fibroid. And you can see that the pregnancy rate after removal of fibroid varies widely between 24 to 72%, depending on the size of fibroid, the number of fibroid, the depth of the fibroid, the size of the uterine cavity, etc. And all these are factors to be considered. That's why we'll have to have patient-specific treatment, not the same treatment should apply to every patient. Now, which fibroid now should we remove? It is quite obvious that the submucosal fibroid, yes, the intramural fibroid distorting the uterine cavity, and the intramural myoma not distorting the uterine cavity if they are large, if they are multiple, or if there is a history of miscarriage, either following spontaneous conception or following IVF. Now, patients frequently ask, doctor, I want to remove my fibroid through laparoscopy or through robotic surgery. Well, of course, we have to differentiate that all options are available, whether conventional microsurgery or whether laparoscopic surgery or whether hysteroscopic surgery. It depends, of course, on the location, and it depends on the expertise of the healthcare provider. Endoscopic surgery could be hysteroscopic surgery, laparoscopic surgery, or robotic surgery, as we have mentioned, as we have heard in the morning, or conventional microsurgical technique. And with hysteroscopy, yes, you have very good results. You have a success rate of almost 96% for the submucous myoma. And of course, the success rate decreases with the advancement of the type of fibroid type 1, type 2, but you have to be aware of the fluid load, which is about half a liter in the 0 type, and it increases up to about 2 liters in type 2. Now, with the removal of hysteroscopic myomectomy, certainly you have a good result and high pregnancy rate of almost 50% in 0 type and 33% in type 1. Now, should I remove my myoma through laparoscopic myomectomy? Yes, laparoscopy is very good, no doubt about this. It has good success rate, but of course it is suitable for patients who have certain characteristics, that is 2 or 3 myomas, and of course you are having the expertise surgeon, and you have all the facilities and all the equipment as we have seen in the first session. But if you do not have the expertise, and if you do not have the facilities and the equipment to perform it properly, certainly you will be far better by doing conventional surgery with myosurgical technique than performing a laparoscopic myomectomy, because otherwise you will do more harm than good. And of course, you should not be worried about the results, because the Cochrane reviews had shown that the live birth rate, the clinical pregnancy rate, and the ongoing pregnancy and miscarriage rate are almost the same in laparoscopic myomectomy or laparotomy and myomectomy, and certainly, of course, the laparoscopic myomectomy has the advantage of being minimally invasive, shorter recovery time, fewer complications, better quality of life. The return to work is 1 week shorter than the time to return to work in the conventional surgery. But you will have to be the experienced surgeon to perform it, and you will have to have the proper equipment. And just a few months ago, I had a patient like this. She has a big fibroid reaching about the deep sternum, and she came and said, oh, no, doctor, I want to have laparoscopic myomectomy. Well, of course, because she has heard on the social media that laparoscopic myomectomy is so and so, and the doctor told me I could remove this through laparoscopy. How can you remove the fibroid reaching the zephus sternum with the laparoscopic myomectomy? Well, of course, certainly the answer, it took me a long time to convince her she should have conventional myomectomy with microsurgical technique, and that is the condition of the uterus at the time of laparotomy. And after the removal of fibroid, we restored the normal anatomy, and these are the fibroids which were removed from this. So how come that you remove this? And then the patient told me, well, but I heard that they can, even this big size, they can do morcellation and removal and reduce the size of this. And you have to be aware of the recent publication of the development of leiomatosis peritonealis disseminata. After doing morcellation, a patient developed 29 tumor varying in size from 1 centimeter to 9 centimeter following morcellation. And the recommendation was that surgical records of the use of the power morcellator in laparoscopic myomectomy is linked to the development of leiomyomatosis peritonealis. Now, so the conclusion of this study, I think it was very well summarized in the recent publication, the COMPARE study. The COMPARE study was a prospective, multi-center study performed in 8 clinics in the United States, and that was performed on a large number of patients, and the period of follow-up was more than 3 years. And what did this study find? Out of 1,060 patients, there were 388 with abdominal myomectomy, 273 with hysteroscopic myomectomy, and 434 with laparoscopic myomectomy, and the follow-up period was for a period of more than 3 years. And when they looked into the live birth rate, they did not find a difference in the live birth rate between those who had had hysteroscopic myomectomy or laparoscopic myomectomy or abdominal laparotomy. The important thing and the important message that you should do the thing which you perform better and don't be worried about the results, because the results will almost be the same if you are doing the job properly. So the conclusion, Mr. Chairman, Madam, ladies and gentlemen, that providing patient-specific care for women with fibroids and infertility remains a challenge. As there was no negative effect on fertility after myomectomy, clinicians may advise myomectomy, as I said, may advise myomectomy in women with fibroid-related symptoms and wish to conceive. When women with fibroid, especially young women, should not be concerned about the specific route of surgery when they desire to get pregnant. Factors to consider are the location of the fibroid, the number of fibroids, the mean size of fibroid, and uterine volume, the age of the patient. Indeed, the age of the patient is the most important determining factor for live birth rate after myomectomy. The experience of the healthcare provider and other associated infertility factor or complaint. Please be careful when you are offering myomectomy, that myomectomy may not result in the restoration of fertility, and this is very important. It has to be very clear to the patient. Risks of hemorrhage, of course, infection, adhesion, scar, uterine perforation, increased risk of uterine rupture should be considered, and every measure should be taken to avoid these complications. Finally, I cordially invite you all to the coming meeting, the 31st International Meeting of the Egyptian Fertility and Sterility Society, which will be held in Cairo during the period of 27th to 28th of November, the coming months. And we have more than 32 international faculty coming to the meeting, and we have meeting involvement of the African Federation of Fertility Society, the International Federation of Fertility Society, and WHO, and many other colleagues participating. So please do come to Cairo and enjoy visiting Cairo and visiting the museum, the Grand Museum, which will be open tomorrow. Thank you very much, Mr. Chairman.
Thank you, Professor Sroor, for your nice presentation. We'll have some time for a couple of questions. Dr. Khaldoon.
Thanks, Professor Abu Sroor, for excellent presentation. My question is, what is the role of non-surgical interventions for fibroids in enhancing natural conception or optimize the success of assisted conception?
Thank you very much. Well, I think this is a very important question. Yes, it does have a place. Sometimes I get a patient who have fibroid, intramural fibroid, projecting inside the uterine cavity. And I said, you know, this projecting inside the uterine cavity, and you will have to have it removed. And then she will say, no, I don't want to remove it. And then I give her GnRH analog for a couple of months, and then it disappears, and they find the uterine cavity. I wouldn't say it disappears, it decreases in size, but the uterine cavity is normal, and then you can go ahead and perform it. Certainly, yes, it does have. But, of course, when you are giving the treatment, then you are postponing her fertility. You know, you know, because if you are going gene-rich analog or other medications, you are avoiding pregnancy in this case. Well, embolization, others, I do not think that they will be useful for patients who are seeking fertility. They are good for patients who are having symptoms like bleeding, hemorrhage, etc. Then they are a good route. But I'm talking about fibroid with infertility problem. Thank you. Yes, please.
Dr. Abdullah.
Thank you, Professor.
Dr. Abdullah. Carry on.
Thank you so much. What to do after recurrent fibroid formation after previous myomectomy, and regarding age, like when she was single, she underwent myomectomy, and then.
Yeah. Thank you. Thank you for the question. You evaluate everything. First of all, what size is the fibroid? How big is the fibroid? How much is it impacting on the uterine cavity? Whether the patient is having symptoms or not. All these factors have to be considered into consideration. If she's having recurrent fibroids and that impeding on the uterine cavity and disturbing, then you will have to remove the fibroid. Just last week I had a patient like this. She had multiple fibroids. And I removed the fibroids, and she was seeking fertility. And then she came back, and the fibroids recurred again with the large size compressing cavity. I removed it, and then we did IVF, and the patient got pregnant. So it depends, you know. The fact that you are finding a fibroid, the patient coming with an ultrasound, she says, "Doctor, I have a fibroid of 4 centimeters, etc., and this is going to impede our fertility." I tell her, you know, if you do ultrasonography for women walking in the street, you'll find 60% of them, they have fibroids. So you don't need to worry about it so long it is not causing you any symptoms, so long it is not encroaching upon your uterine cavity. Absolutely. Thank you.
Professor Sroor. Yeah.
Yes, Dr. Abdullah.
Yeah. Thank you for excellent presentation and highlighting the dangers of morcellation. You neatly shown that leiomyomatosis is a serious risk that doesn't seem to be appearing till recently. My question is, does extrauterine leiomyomatosis has any effect on fertility? Because I think women need to be aware of that, because we have a trend of liberal use of morcellation, and we're seeing a lot of complications and problems as a result of that, which may appear a few months later.
Yeah, well, I think if it is reported, then we should refrain from performing morcellation, as was recommended by the Canadian Society of Assisted Reproduction.
Thank you.
Yeah, it is a risk, you know, and we have to be aware of the risk, even if it was only recently reported.
Thank you, Professor Sroor. I'll give the microphone to Dr. Khaldoun Sharif.
It's my pleasure to invite Professor Yaqub Khalaf again to speak to us about a very important topic that we all get stuck with it in the clinic. Things that work is no problem. It's when things don't work that we need help. And that's going to come from Dr. Yaqub Khalaf. Thank you.
Thank you very much, Khaldoun. And it is completing the story of what we do when things don't work the way we like. Okay, right. How can I move the slides? Yeah. So what I will cover is just a brief introduction to the topic, and then the importance of counseling the patient before, because it's no good to impart on her information after things went wrong, but it's good to manage the expectation. Particular importance of counseling after failed treatment, and what should be done and what should be avoided. In medicine, there is no escape from these 3 essential pillars. People who practice medicine and they would like to practice medicine with confidence, there is no excuse for not having adequate knowledge, for not having adequate skills, and communication skill is as good as surgical skills, as important as surgical skills, and to have the right attitude of doing the right thing for the right reason, not the wrong thing for the right reason or the wrong thing for the wrong reason. So, We know that IVF was not born yesterday. It's nearly 5 decades. And sometimes we act as if we have invented it yesterday. There are about 12, 13 million babies from IVF across the globe. And it is important for us to always focus on the lessons that we had and focus on the essentials and the fundamentals that we have earned over the past nearly 5 decades. The patient's characteristic and baseline phenotype is essential. You cannot make someone with limited potential have 3 babies. They need to know this and get prepared. If the patient is 44, if you send her to NASA, her chances of success will be under 5%. And that needs to be started from, because people come with great expectation. We have artificial intelligence and spontaneous intelligence, and the expectations go up to the roof. And the ovarian reserve. If the patient ovarian reserve is limited, eggs will not come from the supermarket. They have to come from somewhere. And ovarian stimulation, how you conduct your ovarian stimulation. There are some people who are not well grounded. They see a patient with polycystic ovaries. All of his mind is ovarian hyperstimulation, which is great, and end up giving the patient homeopathic dose, 75. You are likely to get at the end of it either 1 or 2 eggs or cancel the patient for poor response. When, if you have the knowledge, you will agree that the best strategy for this patient is to give her a decent dose of medication, use the antagonist regime, give her the agonist trigger, and freeze all, and give her the benefit of 10 plus oocysts in the freezer. And how you conduct your egg retrieval or oocyte retrieval. If you are skilled, you will get the result safely, but if you are not, you can make a mess out of something very simple. How you affect fertilization and the quality control in your lab, the embryo culture, embryo selection, transfer, endometrium, but most importantly, the resilience. If you have it in your head that this patient, more likely than not, she will require another cycle or 2, you will not make her spend every penny she has on the first cycle by all the things that I mentioned earlier that they have no benefit. We have to accept that in IVF there will be no breakthroughs. This is the bad news, I'm afraid, because all the low-hanging fruits have already been picked. 45 years, we had enough time. So there will be no breakthrough, and I stand corrected. So when you talk about pre-IVF ICSI counseling, we have to accept that notion. If we fail to plan, we are planning to fail. If we do not prepare the patient what to expect, how the process is conducted, why are we making those expectations? And when they are good and high prognosis, we share them. When they are low, also we share them truthfully. And as the English will have it, you hope for the best, but you plan for the worst. So you prepare the patient for failure, just as you tell them that we are hoping for success. Pre-IVF counseling task: explain the process and its steps, answer questions. You may have to correct misinformation from Dr. Google and from chat rooms and from my friend who had treatment at another clinic. And you have to manage the expectation truthfully. To tell a patient with AMH of 0.5 that you have 50% chance of success, you are أبو لمعة. ما أعرفش مين حد فيكم يعرف أبو لمعة. عندنا واحد في مصر أبو لمعة كان بيقول كلام من عنده يعني. أوكي؟ الحمد لله. Okay, to explain the steps, it's important to prepare patient for what is involved, whether it is initial consultation, ovarian stimulation, monitoring, egg retrieval, sperm retrieval, fertilization, embryo development. All of these things need to be clarified to the patient. Yes, they may not take in everything, but at least you have done your duty. You have to clear the misconception that the patient gets from Google and Facebook and the chat rooms. And you have to accept that the patient expectation is a straight line. She paid the money, she would like the baby. The true life is totally different in reality. There will be disappointment. There could be failed of fertilization that unexplained. There could be fail of implantation that explained. And our role is really to face those challenges. Challenge number 1 is the mismatch between patient expectation and our knowledge, expectation, and wisdom. Pre-treatment careful counseling is crucial, and telling the patient what to expect is essential. Now, how to manage expectation effectively? You communicate realistic expectation. You speak in ranges. You can say your range is between, say, 25 and 35. It is giving her a truthful picture rather than giving a cutoff point, because that will be pretentious. Back up your claims with case studies. Sometimes you relate to patient that anecdote. I tell them, yes, you are 42, and I can give you probably 10%, but it is our duty to prepare you. But sometimes I tell them about a patient who was 42, had AMH that was so low, the first treatment cycle she produced 1 immature egg. But because she was prepared well, she didn't ask for a follow-up appointment. She asked for just to order the medication. And she had the same medication. She produced 2 eggs, both fertilized. One of them resulted in an embryo, the other didn't. And she must be now 28 weeks pregnant. So that puts things in context. You're giving them figure, but you're giving them that those figures are not cast in stones. I am not a preacher. I am not a religious man. I'm just a mainstream person. But honesty is the best policy. If you tell it as it is, you will protect yourself and you will have conducted your medicine ethically. This curve will not change anytime soon. The age-related decline in the chance of leaving the clinic with a baby. I'm not aware of anything really, and as I said, but I will be delighted if we have major breakthrough to make everything I said wrong. But in the United States, year on year, you will see these figures for patients above 40. The live birth rate for a patient who's 44 is 3%. A patient who's 42 is 6%. These are realistic figures and almost have been constant, despite using everything. And the latest result from SART data talk about patient live births, egg retrieval or birth cycles here. Let's go birth cycle. Under 35, the patient will have 43% chance of leaving the clinic with a baby. But when the patient hit 40 to 41, this will be 8%. That is in the United States, with every piece of technology and every piece of innovation has been used. The cumulative probability of live births after IVF, look here. In a decent clinic in the United States, Boston IVF, after 3 attempts of IVF, only just over 50% will leave the clinic with a baby. That's inclusive of all ages. So we talk about failure. What is failure? Failure is when you as a clinician and your center as a treatment center fail to fulfill patient potential. If you have a patient who is 28, her AMH is high, her anatomy is normal, and you give her 10%, you are really letting this patient down. And if you give her less than 50%, you are failing the patient. But you can't say the same about patient who's 44 and you have 10% chance of success or 5%, you're doing very well because you are fulfilling the patient potential. The counseling after the event is important, and that requires a lot of emotions, unfortunately, because it requires most of all empathy. You know what's empathy? Empathy is when you put yourself in the patient's shoes. You just imagine for a second that this patient has a dream, has a hope, made the investment, endured the injection, endured the procedure, and now she is empty-handed. If you just assume that, then you will communicate to her sensitively, you will communicate to her with support in some way, and of course in different settings will be handled differently. Any patient, when we send that the pregnancy test is negative, we will express our sorrow, arrange a follow-up appointment with the doctor, and arrange a counseling appointment with someone who's trained counselor to address the emotions. The big question that really makes the room run out of oxygen when the patient asks, it is legitimate, why did my treatment fail? And what to do next? And that's where the pressure will be palpable. And it depends on our preparation. We show sympathy with the patient. We worry about the consequences. We doubt that we may have not done everything we could. We decide to go with the flow. Some of us will say, oh, we'll give you that next time, and throw the book at the patient without ration, and decide, do what the patient demands. Disaster. I know some of us accept that whatever the patient demands and she's happy to pay for, we should give it. That's not medicine. You might as well work for Carrefour or Sainsbury's or Tesco's or anything. But you must have an input. If the patient wanted to plan her surgery, you're effectively giving her your white coat. Up to you, but I won't do that. Okay? Some people will lose rationality because they're not grounded. They will use the good, the bad, and the ugly and improvise intervention. And here would come that whether there is good intention and poor understanding does not help the patient. So what is helpful and what is not? What is helpful is to have a strong knowledge base, to know what you're talking about, to highlight the positive. You've done this right, that went right, that went right, but then we put an embryo and you have 3 in the freezer, we still have 3 lifelines. So it is just part of the truth about IVF. Not every embryo is destined to make a baby. Stay rational, be wise, apply your knowledge wisely, and put yourself in the patient's shoes. Remember, patients don't print money. They struggle to get it. And that sometimes is lost on some of our colleagues. Don't help patients lose their resilience, because if they spend all the money they have in one cycle, they will be out of the game, not because they don't have the biology, because they don't have the money. We should always be reminded that wisdom, knowledge, information, and data are all different terminologies. This gentleman said, my father taught me to combine knowledge and wisdom to make an impact. What is the difference between the two? The difference between the two, knowledge is knowing that tomato is a fruit, but wisdom is not putting it in the fruit salad. So if the generic description, it is a fruit, you use your wisdom. It will not make any fruit salad very nice. We need to always stick with doing what is right, not what is easy, because it's easy to go with the flow, but it is most respectable if you are prepared with your knowledge, with your wisdom, with your conviction, and with your honesty to do against what everybody else does, as long as you can substantiate it. The challenge number 3 is the add-ons, which is the plague of our profession. Here is a list of this. I can categorically tell you without reading those, none of them is proven. And you can have a good read and challenge me. None of them is proven. But that is being sold every day. And that's what gave IVF a bad name, because we talk about from assisted hatching to embryo glue, most IVF add-on raced on shaky science and making us appear to be all after money. It's important to appreciate you and your patient that IVF is not rocket science. It is really requiring a competent embryo, a normal anatomy of the uterus, and a good environment that you handle the egg and the embryo's eggs. An embryo that is prepared to implant if it has what it takes, and success that will always be related to biology, and the quality control you have in your lab. That's get forgotten. The lab is crucial, because all those titration and the key performance indicator that decent lab will have and will assist rigorously will be making a huge difference. Having done everything right and you failed, then you have looked back on the cycle. We must learn what can be changed. And we have to evaluate and take time to evaluate. Here is the reflection and action and change. We found out that we really did not go wholeheartedly with our ovarian stimulation. That's why the patient produced 2 eggs when she has the reserve to give us more. We modify our stimulation. The patient appeared to have that structure that resembled hydrosalpinx, but we dismissed it. It could have been the reason. Let's go back and verify, and if it is proven, we do disconnection of that hydrosalpinx, proven to improve treatment. If we have a uterine lesion that we dismissed, a couple of small polyps, we said they don't affect anything, but it wasn't the case in her case, you go and remove them. If there was difficult embryo transfer, prepare yourself with that difficulty and make use of what you learned from previous treatment to change it in this cycle. Non-compliance with medication. The patient may have not taken the right dose at the right frequency, and you discover this, then make sure that the patient may even come to the clinic to be given the medication. So after all, if you are happy that everything was done the right way, keep going. If you find something that needs changing, change it. But the ultimate, as I mentioned in my previous presentation, it is not with add-ons. The best financial strategy is not to waste resources on unproven, unhelpful, and potentially harmful add-ons and save it for another treatment attempt. Because always be reminded of this graph. And if you indulge me for the next few minutes, if I have 3 minutes, I will just show with you a case presentation, one of my international clinical fellows prepared on a patient that had treated in our center. This patient was 33, not known to have any medical problem. She was married with a healthy partner for 13 years, trying to get pregnant since 2017. That must have been 2023 when we saw her. They have one son born 12 years ago by cesarean section, as was naturally conceived. The couple underwent 4 cycles in Doha, 3 cycles in Amman, and 2 cycles in United Arab Emirates. At Doha, they have achieved 1 fresh embryo transfer and 3 frozen. It seems that they have never achieved blastocyst. At a decent private fertility clinic in London, they were seen in October 23. The partner had DNA fragmentation. Why? I have no idea. And that was excellent. She had heterozygous mutation for MTFHR, absolutely no relevance whatsoever. Why do people invest in that? It's beyond belief. And her NK cells, a patient who have issues with reaching blastocyst, we are testing her NK cell. It is akin to doing knee surgery for someone who's coming with eye problem. But that's what happens. Thrombophilia and thyroid, take it from me, thrombophilia has nothing to do with IVF, acquired or hereditary. Nothing to do with outcome of IVF. It is a wasted money. Her AMH was 14.7 picomole per liter, which is almost 2.2 or 2.3 nanogram. Antagonist protocol stimulated with gonal F225 to start prednisolone for the immune system when her issue is not achieving blastocyst, maybe. Aspirin and Clexane. Again, I use the opportunity. Aspirin and Clexane, you can throw them out of the window, and I am responsible. XC for fertilization, PGTA. The patient is desperate for any embryo. There is nothing to select. And sure enough, she produced 1 blastocyst. And they did aneuploid screening, and luckily it was right, and it was put back. So they collected 33 eggs, only 1 embryo suitable for PGTA. It's just people don't have common sense. You do PGTA to select. There is no selection to be had. Yeah. And the result, waited for 2 weeks, so they had to freeze it and then put the embryo back, and nothing happened. Started on contraception. I have no idea why. Then to start down regulation and have another cycle. I will bore you with the detail. It is really very frustrating. She had the embryo transfer, sadly unsuccessful. They planned to start new cycle with the same regime, 3 fresh attempts. The second cycle started another XC. She had this and that and the other, and she was tested with ERA test. You know what is ERA test? Fine. Where is the relevance here? And it costs 1,300 pounds. And Emma and Alice test, that sounds like a novel, not a test, and then failed. Then that was the recommendation for her. She came with a letter when she came to us. That was her next step. I can't read it, but I can tell you. To have prednisolone 25 milligram from day 3, to have Clexane 20 milligram daily from day 7, intralipid infusion from day 7, uterine PRP on day 7 and 11, HCG injection during embryo transfer. In the center of London. I hasten to say, sadly, that the guy who gave her all of that recipe was Egyptian. how proud I am. Yeah, an example of what happens, and it's not Taranisi, by the way, not to be, no, it was somebody else, yeah. He will do the same, but it wasn't him. We have to be fair. So that is an example of what happened, but should not be happening. She came to guys, not because we are shagi' al-sima zay ma biqulu. That is exactly word for word. I didn't have anything to do with preparing this case. Even did not try to make it look better. The couple came to be treated at Guy's ACU. History was reviewed. Semen analysis and male virology screening were normal. Female screening virology was normal. AMH was 14.9. That's all the pre-treatment investigation we did. Then she started a fresh cycle with stimulation with Minipure HMG 300. Egg collection on 12th of August, she produced 24 eggs. We checked and we said she could develop hyperstimulation, let's freeze. We have a policy, if she had less than six or less pronuclei, we freeze at this stage. Above this, we culture 2 cells. So we froze at 2 p.m. In 26th of August, started medicated FET, received 8 milligram estradiol per day, and supported with cyclogest when the endometrial thickness was good, and she was given also subcutaneous injection of progesterone. On the 7th of September, had 2 cleavage stage embryos. The one was 6-cell and one was 7-cell. Ultrasound, she had post-pregnancy test, and ultrasound, so single viable intrauterine pregnancy, 6 weeks of gestation. No add-on, no add-off, no add-at, no add-from. Thank you very much.
Thank you very much, Yaqub. I'm sad to say that we do see these things everywhere in the world. I wish they were rare. And you asked what's the value of these tests. When my patient asks me, well, they must have a value. And I say, yes, they are very valuable. They tell me that the clinician who has requested them hasn't got a clue about IVF.
Yeah.
Any questions? Sir, the mic for my friend there, please.
Thank you very much, Professor, for a very informative lecture. Now, we all keep talking about adds-on and unnecessary medication and procedures in IVF. But the question is, when we are going to take measures against the clinicians who keep doing this day and night in Jordan, in Palestine, and everywhere else, the scenario we're talking about, we almost see it every week. And the PRP market in Jordan, I think, very well developed. I see patient coming, where are you going to Jordan? For PRP, for ovarian rejuvenation, for everything, etc. Now, the regulatory bodies are here. When we are going to take action to say this is, sorry, we have to stop all this mess. We have the Jordanian Society, we have the Palestinian Society, we have the Medical Council, we have the Ministry of Health, and none of them are doing anything.
You know the answer? The answer to all problems of the world is education, education, education. That's the only thing we can do, because even in London, which has the best and the longest running regulatory body in the whole world, the Human Fertilization Technology Authority, we have established the traffic light system. When I was in charge of the Scientific Advisory Committee, people know the patient have access, but still some people will do how they please. There is no legislation to say take them to prison. This is bad practice that should go back to your ethics of conducting yourself. You don't change the world. If you change yourself, will be a good start.
Thank you. Any other questions? Dr. Khaldun Khamaisi, please.
Thank you, Yaqub, again. About the case you presented,
Yeah.
It's just interesting that she has a good ovarian reserve.
Yes.
She produced good number of eggs, but the fertilization was low. So I think wherever she did her IVF, she ended up with the same. So I think it's a matter of chance. You know, when you have the fertilization is low, I think agreeing with you is that adding too many add-ons is not going to benefit. I think you deal with what you have. Exactly. But it's interesting that she has a low fertilization rate.
Yes.
So,
But it's not an excuse to give her PGTA.
Yeah, there's no point.
It's not an excuse to give her steroid and IVIG. Okay, so that is the point, because those patients, as I say, you just need to invest in repeating the treatment and rationally. If we had to do 2PN freeze, we found that there has 2 day 3 embryos. What is to be gained from culturing them any further? The better in than out. Simple.
Thank you.
Any other questions? Okay, thank you very much,
Thank you.
Yaqub. Thank you.
Thank you.
The last but not the least lecture in this session. And after that, we'll have the lunch break. Professor Sarur is going to talk about infertility management in women of advanced reproductive age. He considers more than 35 years. Yes, Dr. Sarur.
Thank you very much, Mr. Chairman. Well, I got the message from the chairman that because lunch will be after this talk, so I'll have to be brief. Well, I would like to thank Professor Yaqub, actually, if he's here, for his talk, because actually he made the introduction to my talk, and probably I don't need to speak. But anyway, I'm going to go through the infertility management in women of advanced reproductive age, because this has been a subject of great interest recently. Well, I have no conflict of interest, and I'm going to talk about fertility in advanced reproductive age, whether spontaneous conception or after IVF, and why do women delay reproduction to advanced reproductive age, and what are the results of ART in advanced reproductive age, and the cost implications, and the childbirth implication as well, and then finally, how can we prevent and manage this patient who wants to conceive at advanced reproductive age. Advanced reproductive age, there is no consensus regarding the exact definition of advanced reproductive age, or ARA. ARA is usually defined as being 35 years or older at the time of giving birth. There has been less focus on the impact of ARA in the male, which has recently become of great interest, and several publications on the role of the advanced reproductive age of the male as well on the outcome of reproduction. A long time ago, WHO, in a study of DHS of 47 countries, had shown that fecundity of women, that is, the ability to conceive, decreases with advanced reproductive age, and it sharply increased after the age of 35, and markedly increased, exponentially increased after the age of 40. And in Jerusalem, there is an isolated community where they don't use contraception, and they continue to have children as late as possible, and it is only 0.2% of women at the age of 45 they could get pregnant, which shows that with spontaneous conception, the chances, of course, markedly decrease. Because we do get this question when patient comes tell you she's coming for IVF and she's 45 or 46, and she tells you, I want to have IVF. You said no. And then she said, but my neighbor, she got pregnant when she was 46. There is a difference between the spontaneous conception, because spontaneous conception, it does occur after repeated and prolonged attempts at getting conception, while IVF is only applied for one cycle or only a few cycles. Now, over the past 4 decades, indeed, there has been a dramatic increase in the number of women at the age of 35 and above giving birth, reaching in the developed countries around 10%. And regrettably, positive media portrayals of having children in advanced reproductive age, particularly among celebrities, increased the societal acceptability of this choice. We all remember Meryl Streep, who got pregnant at the age of 45, and she delivered her first child when she was celebrating her 42nd birthday. And look at this, the misinformation from people working in the field of IVF. Look at this, القضاء على العقم خلال شهر حتى ولو كان المخزون 0 وحتى لو كان العمر 50. العلاج الخارق للحمل مخصص للأعمار 45 ل 55. تنزيل الدورة، رفع المخزون، زيادة الخصوبة، ضمان الحمل 100%. انسى ضعف المخزون. And I am saying this in Arabic because I am ashamed actually to say it in English, because this is some of the advertisements which we see on the social media, and patients, they are excused because they listen to these things and they come and ask for these things and say, your colleague is saying such and such. And when you look in the IVF, say, when you look in the registry of IVF in Latin America, you find that 70% of the cases of ART are being performed for women at the age of 35 and above. And when you look into this analysis of 86,000 cases from the United States, you see that 40%, only 40% of patients had IVF below the age of 35, and 60% of them, they had IVF at the age of 35 and above. And when you look into the global report of ICMART, International Committee of Monitoring of ART, which reported on 3.5 million cycles performed globally, there have been found differences in the incidence of percentage of IVF in the different age group based on the use of autologous oocyte, on the policy of the center, on the cost of the treatment, on the coverage of the treatment, and on the availability as well of egg donation, and on the reproductive health information among the public and the dissemination of information in that country. Long time ago, Professor Alan Templeton had shown that even in IVF, you have a marked reduction of the outcome of the live birth outcome of IVF, particularly after the age of 40. It does decline at the age of 35, but it steeply declines after the age of 40. So whatever you are talking about, natural conception or IVF, the fertility does go down. And the embryo quality, well, of course, your patient asks me, why don't you look for my embryo quality? Well, even if you look at the embryo quality through and endometrial receptivity, of course, these are the main factors. So when you look at the embryo quality, we all know that with the advanced age, you get decrease in the number of the oocyte, you get increase in the number of abnormal oocyte aberration in the oocyte, and this increase after the age of 35 and sharply increase after the age of 40. And long time ago, Michael Hull had shown that below the age of 34, only 24% of the oocytes are abnormal. But when you reach the age of 40, more than almost 96% of the eggs are abnormal. Professor Yaqub had shown this slide in a different form. There are several factors why we get poor quality of oocyte with advanced reproductive age, for so many causes for that. And it had been shown recently that the ability of the metaphase 2 oocyte to produce a single euploid blastocyst decreases with increased age. And it sharply decreases after the age of 40, and it does decrease indeed after the age of 35. And this work had shown that to produce a single euploid blastocyst from a metaphase 2 oocyte, you need at the age of 37, 11 mature oocyte to produce a single euploid blastocyst. And later on, Rodrigo as well had shown the same, that for a patient who is 39 years old, you need 16 metaphase 2 oocyte to produce a single euploid blastocyst. So you can see how that the quality of the egg does affect the outcome of IVF, and you do need to have a large embryo. And this is the typical example of which Professor Yaqub mentioned, that when that patient produced a number of embryos, then one of the embryos was euploid, and of course it was transferred for the patient. Now, we always thought of the quality of the embryo as the determining factor, but very recently this concept had been challenged, that the only embryo factor drives the detrimental effect of age on the reproductive outcome. This study, this recently published study, reveals that even uterine age, with the advanced reproductive age, it has a detrimental effect on the outcome of IVF. So it is not only the embryo, but also it is the endometrium. And this study, which was performed, it was a retrospective study performed in 19 centers in Europe on the 33,000 IVF cycle obtained from egg donation from a young patient less than the age of 35, so the quality of the egg was fine. The donors of the egg were less than 35, and they were implanted in patients with advanced reproductive age. Look at the outcome. The relative risk of implantation failure at the age of 40 increased by 4% every year. And the relative risk of pregnancy loss, miscarriage, increased at the age of 40 and above by 3% for every year, which shows that when you transfer euploid embryos in an elderly patient, you do get reduction in the implantation rate, which again implicates the endometrium in the elderly patient. And the inflection point for live birth rate is at the age of 40, and the inflection point for the pregnancy loss at the age of 43, and for the implantation failure at the age of 39. So the endometrium as well, it does affect the outcome of IVF with advanced reproductive age. Now, then the patient tells you, okay, as the patient of Dr. Yaqub, her doctor told her this, to look at the quality of the embryo. So you're going to look at the quality of the embryo, whether you're going to do morphology, time-lapse, imaging, artificial intelligence, invasive method, PGTA. PGTA is not going to increase the live birth rate. It is going only to shorten time to pregnancy, and it may decrease the miscarriage, but it's not going to increase the live birth rate, because if you transfer the embryos, then you transfer that. So there's no point of paying a lot of money for such technique. Again, she will tell you, measure the endometrial receptivity. We all know that all the results of the endometrial receptivity, as Yaqub mentioned, including the ERA, they are not effective whatsoever. And even the recently proposed trophoblastic spheroid onto endometrial epithelial cells, it proved that it has no value for patients of advanced reproductive age. So really, you do not have any facilities to differentiate between the cause of the failure, whether you are assessing the embryo or assessing the endometrium. And when you look at the results of ART in advanced reproductive age, excuse me, from the different parts of the world, this is the studies from the United States, over 86,000 IVF cycles. Look, the cancellation rate was 5%, for patients less than 35 was less than 5%, while the cancellation rate for patients at the age of 40, it was 20%. And when you look at the live birth rate, the fresh live birth rate, for patients at the age of less than 35, it was 21%, and then it decreases gradually till 4.6 at the age of 40 years old and above. And that's for the fresh cycle. However, when you look at the live birth rate with frozen embryo transfer, the story is not the same. You have a higher live birth rate with the frozen embryo transfer, even in patients at the age of 40 and above. But this is not because of that these patients are 40 years and above. These are because of these are good quality patients who produce a number of oocytes which could have cryo embryos to be transferred for this patient. And this is an important message which we should relay to our patient. If you are elderly patient, but you have had embryos collected from you at a younger age, yes, you have a higher chance of pregnancy when we transfer these embryos. Whether you have cryopreserved embryos or whether you have had cryopreserved oocytes collected from you at a younger age. And again, also was shown at a global level by the ECMART, which had shown that for women at the age of 40 and above, still you have a reasonable live birth rate for patients when you do a frozen embryo transfer, as I mentioned, because these are good prognosis patients who had large number of oocytes. I will share with you our experience, which we published more than 15 years ago in Fertility and Sterility, and that was on 2,300 cycles. We looked into the impact of age on the outcome of IVF. And we found that the cancellation rate of the oocyte pickup was 16%, as you can see. And then the cancellation rate of the embryo transfer was 11%, which means that 27% of patients at the age of 40 and above coming for IVF, they did not reach the stage of the embryo transfer. 27%, either the drop of the oocyte pickup or the drop of the embryo transfer. And when we looked at the live birth rate, it was almost 7%. But because these patients were different groups, all of them, they were above 40. It is important when you counsel your patient at the age of 40, it's different from the patient at the age of 43. So we looked into that paper, into the live birth rate of patient at the age of 40, it was 12%. At the age of 41, it was 8.5%. At the age of 43, it was 3%. At the age of 45, it was 1%. So not all patients above the age of 40, they have the same live birth rate. And this is an important message to relay to your patient when you are counseling her. Again, when you looked into the miscarriage rate, it was 40% at the age of 40, but it increased to 60 or 70% at the age of 44. And when we looked at the cutoff point for this patient, there was significant difference in the live birth rate between the patient and the increase in the miscarriage rate between patients at the age of 40 to 42, and the cutoff point was 43 years of age. And at the same time, the study from the Japan register as well had shown exactly almost the same result with live birth rate, the red column, live birth rate of 8.5% at the age of 40, and it decreases gradually to reach to 0.8% at the age of 44. So almost exactly similar to our group. But, and also, when we looked into the most recently published data from the SAR, from SART, again, for patients less than the age of 35, the live birth rate was 37%, while for women at the age of 41 was 9%, more than 42 was almost 3%. But an important implication in this issue as well is the cost for the patient. And this has to be relayed to the patient when you are counseling her. And when we looked into our cases, the 2,300 cycles, we found that for the age of 43, the cost of the cycle was all to achieve one live birth rate, to achieve one live birth was almost 500,000 Egyptian pound. At the age of 45 and more, the cost for achieving one live birth rate was 2.1 million. It doesn't mean that the patient paid the whole amount of money, but this is the cost which the different patient paid till we got one live birth in this patient. Again, the Australian group, they have shown the same, that the cost for obtaining one live birth rate at the age of 45 was €750,000, euros, while the average one was only 26,000. And it had been shown that if you have a live birth rate less than 5, then the cost of the IVF cycle will exponentially increase if the live birth rate is more than 5. But also, we have to be aware and counsel our patient about the risk associated with reproduction in advanced reproductive age. The risk for the offspring, the risk for the health of the mother, including hemorrhage, sepsis, anesthesia complication, admission to intensive care unit, cesarean section rate, and also the risk for the child to be born. And this had been neglected in the past. Children born to elderly patients, they do suffer. They do suffer fear, they do suffer excitement, they do suffer emotional struggle, depression and anxiety, behavioral problem, because when they look at their peers who have younger parents, they are different from their parents who are older, and they worry whether they will continue to live with them and look after them. So when we come to the important question, how are we going to manage this patient? Well, certainly the most important issue is prevention. Prevention of pregnancy at advanced reproductive age. And this will come only through health education, proper health education. Women have to be aware that their fertility declines with age. And if they want to plan to have a child, whether naturally or through IVF, they should do this as early as possible. However, if we are confronted with patients who is coming to get pregnant at the advanced reproductive age, then we should forget the normal definition of infertility that you investigate the case after 1 year. You should investigate them as soon as possible. And if they have a male factor, mild male factor, you may do IUI. If they have severe male factor, you should shift directly to IVF. If they have tubal factor, you don't do tubal surgery, you shift directly to IVF. If they have ovarian factor, you do short period of stimulation. And then if they don't respond, go to IVF. And if they come to you with unexplained infertility, you immediately do either IUI with stimulation. If they don't get pregnant shortly, then you shift for IVF. However, we do see some of these patients who had some reproductive problems, like multiple myomas or hydrosalpingosis, etc. And in these cases, because if you wait for too long, then they might lose their fertility. So we may do the deferred embryo transfer. You do stimulation, do pickup, fertilize the eggs, and cryo-preserve the embryos, do the reproductive surgery, and then after doing the reproductive surgery, do the deferred embryo transfer. So you are not losing time, and you are obtaining the oocyte at a younger age. And we have to be aware of the ethical issues with reproduction in advanced reproductive age, including access to ART is a reproductive right. I have some of my colleagues who would refuse to see a patient who is at the age of 40 or above, because they don't want to have a lower results of IVF, which is extremely unfair, actually, for the patient, which is not a good medical practice. We have to be aware of the welfare of the offspring, and the potential maternal risks, and the issue of non-discrimination and discrimination. So counseling IVF and ICSI in women at the age of 35 and above using autologous oocyte is associated with a low live birth rate, which declines with 1 to 2 years age increment, particularly at the age of 42. And this is important in our counseling. The patient who is 40 is different from the patient who is 43. For physicians to refuse treatment on the arbitrary basis of age alone in women less than 43 years of age is unjust and not fair. Assessment after, yes, you assess her after the first IVF cycle, and if she is good responder and produce oocyte, then of course you carry on, and even you may repeat the procedure if she is a good prognosis patient. Women aged more than 43 years should be very carefully counseled about the low chances of their pregnancy, and they should be discouraged from undergoing IVF using their fresh autologous oocyte in favor of other alternatives. But of course, if the patient insists, you have to be honest with her and tell her the success rate of IVF in this patient. In women more than 35 years, the use of autologous frozen oocytes or embryos obtained at a younger age is associated with a high live birth rate, almost comparable to women less than 35 years, depending on the age of the woman at the time of freezing embryos. And you have, if your patient gets pregnant, then also you have to look after her pregnancy. You might give her low-dose aspirin to prevent preeclampsia. Of course, a frequent antenatal visit and monitoring of her pregnancy and scanning. And of course, we should not let pregnancy to go too far because of the risks of intrauterine fetal death. And of course, other alternatives are available, like egg donation or freezing, which is not permitted in this part of the world, but also egg freezing or cryopreservation of oocyte are alternatives. In future, in vitro-derived human gametes, which has been successful in animal experimentation but not applicable in human being, could be a hope for the future. And finally, again, I repeat my invitation to our coming 31st international meeting in Cairo. All of you are cordially invited, and we look forward to seeing you all. Thank you very much, Mr. Chairman.
Thank you, Professor Saroor, for your nice presentation. It's time for questions. We'll have a couple of questions before the break.
Yes, hello again. It's me again. How do you manage a case that happens to be very frustrating? The woman is 32 years old, husband 40. They have been married for 4 years, seeking children. Twice, 3 times gets pregnant, positive pregnancy test, and then negative. Then after many attempts, we counseled her, and we did IUI twice, no pregnancy. IVF, she had 16 eggs, out of which only 6 embryos. Transferred once, no pregnancy, only chemical. Second time, 2 embryos, again chemical. So what to do next? She has a very negative attitude. I happen to feel that it's part of the failures. Maybe I'm wrong, but she keeps saying, I'm anyway not going to be pregnant. I'm anyway not going to get a child. So how do you go about convincing her to keep trying and trying and trying? Because it gets exhausting psychologically and money-wise, like you know. Thank you.
Thank you very much for this very important practical question. All what we need in this case is counseling, proper counseling. I mean, as all of us know, that proper counseling is informative counseling, providing her with the information and the prospect of her getting pregnant, supportive counseling during the treatment, and then, of course, when she fails, you do need to continue with the counseling. And you explain to her her possibilities, and some of the patients say, still, doctor, I am willing to carry on. If she is willing to carry on, again, you give her the proper information, support her. And if still she fails after several times, it is up to her. If she wants to continue, as long as she is producing eggs, as long as she is producing good quality embryos, I will advise her to continue, provided that I tell her that the very low chance of her pregnancy. I mean, you have seen the case of Professor Yaqub. She did, I think, 9 cases of IVF, and eventually she got pregnant at the cycle at St. Thomas's Hospital. Yes. I remember in the very good old days of IVF, I was visiting Johns Hopkins, and I have seen a patient there, and she got pregnant after the 27th cycle of IVF. So I told my colleague, Dr. Baramki, how come that you performed 27 cycles? He said, no, she performed cycles somewhere else, and she came for them, and 27. She was producing eggs, and they carried on, and she got pregnant. So there are very little chances, but you have to give her the chance if she wishes so.
Dr. Barghouthi, please.
Thank you, Dr. Sroor. Is there any age limitation to start IVF cycle? At what age you tell your patient, I can't start IVF cycle? Or it depends on the lab test and ovarian reserve?
I think it should be patient-centered. I mean, if you have a patient who is 45 years old, and her AMH is 0.05, 0.01, and she is 45 years old, and she's having irregular cycles, then certainly I would advise her against IVF, and I would not perform IVF for her. But if she is 45, and her AMH is 1, and she's having irregular cycles, and then I would tell her that, well, if you want to have IVF, your chances of pregnancy is less than 1%, your chances of miscarriage is 50, 60%, and it is up to her to choose whether she go ahead with it or not. She will tell me, what's your opinion, doctor? What you do advise me? I said, sorry, I cannot advise you. I provide you with the information, but the choice and the decision is yours and the decision of your husband. Yeah.
Last question.
And the same if the age above 45.
As I mentioned, if she is regularly menstruating, if her AMH is reasonable, and if she performed last cycle last month, and she produced 7 oocytes, and she produced 4 embryos, good quality embryos, why not to repeat again?
Dr. Nawaisa, last question.
Thank you, Doctor, for your interested lecture. I will be asked you about the age of 43 as a cut-off age for your, if there is any point in the literature as a biochemical level that is differentiate between the endometrial cavity in the 43 or above or below between the ages?
Yeah, the very recent study which I have shown, actually acted on this point, and it indicated that there is a difference in the implantation rate and there is increase in the miscarriage rate with advanced maternal age. So even if you have good quality embryos, it doesn't mean that they are going to implant, because there is increased risk of failure of implantation by 4% every year. 43, 44, and if she is producing good quality embryos and you transfer good quality embryos, but her age is 45, again, there is a decrease in the implantation rate of her endometrium. Yeah. And you have no way whatsoever of assessing the ability of the endometrium for implantation. As Professor Yaqub mentioned, the ERA and others, they proved to be of no value. The recent one, the spheroid, proved to be of no value for elderly women.
Thank you, Professor Surur and Professor Yaqub.
Thank you.
I think we should come back at 2 o'clock for the third session. No, sorry.